Yes, Dr. Guru.
Yeah. Thank you, Dr. Sharma, for kind invitation and introduction. I think it's nice to go back to our pharmacology thing because it's actually a cycle. You start learning your basics in medicine, and then you go on to clinical field. Then coming back to again basics like pharmacology is interesting and challenging at the same time. As you are all aware, there are a lot of things, new things happening in the field of neurology. We had a new thrombolytic agents like alteplase, tenecteplase coming in. We had a lot of new drugs coming in various subsections of neurology. But in last 10 years, the newer anticoagulant like dabigatran has made its presence. And as we see a lot of patients requiring anticoagulation, we need to be aware of the use of NOAC in our practice. So in that sense, it's not a drug where we don't come across a situation where we need to use it. So it's a very commonly prescribed medication at this stage in our practice. It's easily available, not only on dabigatran, other NOACs as well. So when I'm doing this talk, there will be references to other NOACs as well, because when you compare the single drug with other peer drugs, then you will have the understanding is much more better, and then we'll see what are the indications, what are the contraindications, and how do you place dabigatran in our current practice. So it will be essentially clinical. I being a clinician, it will be quite a clinical talk, but definitely there will be uh, basics about the drug and its mechanism of action and all. So, what is the role of anticoagulation in stroke? Dr. Sharma, myself, when we're doing our MBBS and MDs and all, we used to use anticoagulation, mostly heparin, very randomly without much. I think most of the stroke patients being admitted, we used to use heparin without much, clear indications and its role. But over the time, its use in acute stroke or in chronic stroke situation has come down. So there are clear-cut indications of use of anticoagulation in stroke patients or otherwise by neurologist. So when we look at the role of anticoagulation in stroke, we look at conditions with potential high risk of early cardiogenic reembolization like atrial fibrillation. You can have a look at a situation where there's a dissection of the arteries, carotids or vertebral arteries, or symptomatic extracranial or intercranial arteriosclerotic stenosis with crescendo TIS or early progressive stroke. Again, that's a little gray area. We are not sure. We don't have clear evidence whether there is a role of anticoagulation, but still sometimes we use it. Basilateral occlusions, when there is a crescendo stroke in basilateral occlusion, either after arterial or mechanical thrombolysis, sometimes you use anticoagulation for some time. Uh, or known hypercoagulative states, whether it is thrombophilic states like protein C, protein S deficiency, or antithrombin 3 deficiency. And our role will become very important in as a neurologist becomes in the CVT, cerebral venous sinus thrombosis. I think we'll go into detail of that later. So, in specifically in speaking about stroke prevention, cardiac conditions, stroke prevention after MI, whether there is a left ventricular thrombus, there is a left ventricular aneurysm, persistent or paroxysmal atrial fibrillation, or in other heart conditions like you have a mechanical valve or a mitral stenosis, left atrial myxoma. Here we in discussion with the cardiology team, we discuss with them the risk of thromboembolism, strokes in such patients, and then decide the type of anticoagulation we use in such patients. And also, there are situations where you have a large patent foramen ovale, and you can have a recurrent cerebral ischemia related to that. So if they are refractory to aspirin, so there is a role for anticoagulation. Or if there is a co-occurrence of PFO with atrial septal aneurysm, or there is a DVT with PFO, then this becomes an indication for oral anticoagulation. So these are the various situations in cardiac condition where you need to look at starting on oral anticoagulation. So what are the available anticoagulants so far? So we had parenteral and oral anticoagulants. In parenteral anticoagulation, we've been using heparin for so many years now. Low-molecular heparin has now almost replaced the conventional heparin. These acts on factor 10A and thrombin. The specific thrombin parental drugs are bivalirudin or argatroban or hirudin. These are usually you come into picture in practice when there is heparin-induced thrombocytopenia. So that's when you use it. Or fondaparinux, which acts again on factor 10A. Coming to oral, all this while, so many years, almost for 50 years, we've been using vitamin K antagonists, whether it's warfarin or acetron. We have the newer ones which acts directly on thrombin, like dabigatran, the present day stock, which are direct thrombin inhibitors, or the newer drugs like rivaroxaban, apixaban, or edoxaban, which acts on factor 10A. So, speaking about warfarin, it acts on mainly vitamin K dependent factors like 7A, 10A, 11A, 10A, and 2A. So it has different, roles as a anticoagulant. Whereas heparin, low molecular heparin acts on 10A, whereas unfractionated heparin acts on 2A and 10A. The direct thrombin inhibitor, as you can see here, it acts on the thrombin. It's basically there are direct thrombin inhibitors, the dabigatran, the argatroban, or these are the parental ones. This is the oral anticoagulant. So what was because we've been using for so many years, 10 years of warfarin, what was the problem with warfarin? We all know that we have been through this. We've been using it for so many years during our practice. The most important is the slow onset of action. It almost take 4 to 5 days to the onset to start. And we need to overlap with heparin, as we all do for many years. It has multiple drug and food interactions, especially the patients have to be on, we need to avoid vitamin K rich food. And that becomes an issue because that can't be monitored. And quite a narrow therapeutic window. The PT prothrombin time INR can fluctuate so much, and there can be issues with bleeding risks. That again leads to close monitoring of prothrombin time and international normalized ratio, and it can be sometimes very difficult to in practical terms, and that again leads to frequent dose adjustments. Nowadays we use WhatsApp and communication to do that, but still that doesn't take away in terms of the inconvenience to the patients and all. And then so much of inter-individual differences in terms of predictable anticoagulant effects. So each individual is different. The dosing requirement for each individual differs. So much of issues with the use of the conventional vitamin K antagonist. So that reason there is always a constant lookout for the more specific anticoagulants, which are much more easier to use and with predictable anticoagulant effects. In that sense, in last in the early 2000. So the 50 years till 2010 was the warfarin era. From 2010, since the approval of dabigatran in 2010, we have a surge of new drugs, NOACs, starting from rivaroxaban in 2011, apixaban in 2012, edoxaban in 2015. But speaking about NOAC, dabigatran was not the first NOAC to be tested. Before that, what are the advantages of NOAC? It has rapid onset of action. So that means there's no bridging required with heparin. There is a predictable anticoagulant effect. So you don't need to routinely monitor the coagulation monitoring. There are certain situations where you need to do that. I'll come to that later. And there's a specific coagulation enzyme target rather than multiple levels of action like in warfarin. It has a specific effect on the thrombin. So what it means that there is a low risk of adverse effects, mainly the bleeding. Low potential for food interaction, so there's no dietary questions required. There is low potential for drug interactions, but there are some interactions we need to be careful, but not as much as we do it with warfarin or acetron. So as I said, dabigatran is not the worst drug which was initially approved. It was the ximelagatran drug, which was introduced in 2004 or 5, but for DVT prophylaxis. But sooner it was, seen that there's a lot of hepatic toxicity associated with this drug, and it was withdrawn. So for almost 3-4 years, there was no other, direct thrombin inhibitor, and then dabigatran went through rigorous trials, and then it was approved for use in 2010. So dabigatran is the first NOAC approved for use in, venous thrombus prophylaxis, and for stroke prevention in atrial fibrillation. It's a potent, rapid, reversible, and direct inhibitor of thrombin. It has a very good efficacy, safety, and tolerability profile as compared to low market heparin and warfarin. We'll go to the trials. It inhibits thrombin both with concentration dependent and competitive fashion. It also acts on both free thrombin and clot bond. So this is how the molecule of dabigatran etexylate looks like. It's a prodrug, and it gets converted into active moiety once it's absorbed and goes through first pass metabolism in liver. And basically, it is it's a complex molecule. Basically, the unique thing about it is the benzamidine ring. What you see here. So it's basically alanine ethyl ester. So dabigatran etexylate is a prodrug which gets converted to the active moiety dabigatran. Oral bioavailability is only 6%. It is predominantly excreted via renal route, mostly unchanged, and very little is metabolized in the liver. So, whereas dabigatran etexylate acts directly on the thrombin, rivaroxaban and other NOACs acts on factor 10A. So thrombin is very important, not only just in terms of converting fibrinogen to fibrin. It also has effect on the platelet aggregation, further enhances. So when you look at effects of the dabigatran, it's not just effect on the thrombin per se. It prevents, it acts on thrombin, which in turn is responsible for conversion of fibrinogen to fibrin. There's a positive feedback amplification of coagulation activation, cross-linking of fibrin monomers, thrombin-induced platelet activation. So what you see here, which acts through the PAR receptor, which causes G protein signaling, and which leads to shape change, activation of GP2B3A receptors, degranulation, and that aggregation is important step in the clot stabilization, which is actually the first step of platelet aggregation and all. But the thrombin has effect there as well. So when you are saying the mechanism of action of dabigatran, it no doubt is a direct thrombin inhibitor, but thrombin has a very complex role in the coagulation cascade. So that is most important. So it also has a role in the inhibition of fibrinolysis. So what was the landmark trial in dabigatran? So it was published in New England Journal of Medicine in 2009, where they compared dabigatran versus warfarin in patients with atrial fibrillation. So this is basically the RELY trial. So in this non-inferiority trial, they randomly assigned 18,000 plus patients who had atrial fibrillation and a risk of stroke to receive. So if you look at the CHAT score here, it was around 1 to 2 in a blinded fashion. Fixed doses of dabigatran 110 mg or 150 mg were used. And dose-adjusted warfarin is used in unblinded fashion, because warfarin patients required monitoring of the PT-INR, so it could not be completely blinded. And the median duration of the follow-up period was 2 years. The primary outcome was stroke or systemic embolism. The primary outcome in this trial was in the warfarin group, it was on 1.69% per year, as compared to 1.53% per year in the group that received 110 milligram of dabigatran. Relative risk of with the dabigatran was 0.91, and it was statistically significant for non-inferiority, whereas 1.11% per year in the group received 110 milligrams of dabigatran. So you can see there's a significant difference between 150 and 110 milligrams. The rate of bleeding was 3.36% in the warfarin group, as compared to 2.71% per year in the group receiving 110 milligrams, and is almost comparable to warfarin in the 150 milligrams, that was 3.11%. The rate of hemorrhagic stroke was 0.38% in the warfarin group, as compared to 0.12% in 110 milligrams of dabigatran, which is statistically significant, and 0.10% per year, which is also significant with 110 milligrams. The mortality rate was 4.3% per year in the warfarin group, as compared to 3.75% per year with 110 milligrams of dabigatran. And in 150 milligram group, it was 3.64%. So they concluded that in patients with atrial fibrillation, dabigatran given a dose of 110 milligram was associated with rates of stroke and systemic embolism that were similar to those associated with warfarin, as well as lower rates of major hemorrhage. So it fulfills the criteria of non-inferior. Whereas dabigatran administered at a dose of 150 milligrams as compared to warfarin was associated with lower rates of stroke and systemic embolism. So 150 milligrams was better than 110 milligrams, but similar rates of major hemorrhage. So this was the landmark trial, and that opened up for the approval of this drug for these indications. And not only that, there are other trials which were done for the thromboprophylaxis in patients who undergo orthopedics procedure. Basically, in these trials, it was the hip replacement surgeries, and these three, the Recover 2, and Remedy, were non-inferiority trials, whereas the Resonate trial was a superiority trial. So again, they all three trials showed that dabigatran, as compared to, in these two trials, it was compared to heparin, whereas these two trials were compared to this Remedy trial was compared to warfarin, whereas Resonate trial was compared to placebo. So in terms of prevention of VT and deaths, it was found to be non-inferior as compared to the comparative drugs. And it was also proven to be safe. In all the trials, dabigatran was found to be safe. So you have good trials in atrial fibrillation and CVT in terms of thromboprophylaxis in patients undergoing orthopedic procedures. So as compared to other NOACs, how do this fare in terms of pharmacology? So the direct factor 10A inhibitors like rivaroxaban, apixaban, and daxaban, the bioavailability is much more as compared to, I think, and there is no pro-drug involved in these two drugs. They are the active drugs themselves. Renal excretion is 80% in dabigatran, whereas compared to rivaroxaban is 35%, 25% in apixaban, and daxaban 50%. So the safety in using patients in having impaired renal clearance is much more in these three drugs as compared to things. So that's one thing which we need to keep it in mind when we're using thing, because the common indications, as you understand, for NOAC for neurologists, use stroke prevention, atrial fibrillation. So that's was a very common indication. So most of these patients are elderly; they are in 70s, 80s, and all. So we need to be very careful when we're using these drugs. We need to be measuring the renal clearance of creatinine, and then take up use of this NOACs. Liver metabolism very minimal in dabigatran as compared to rivaroxaban, apixaban. GI side effects, these three drugs don't have much GI side effects, whereas dyspepsia is seen with the thing. Basically, because of the capsule, it has basically tar-coated capsule used in dabigatran, that causes some amount of dyspepsia. The dosing is BD in dabigatran and apixaban, whereas OD dosing in rivaroxaban and daxaban. Coming to further pharmacological characteristics of NOAC as compared to warfarin. So the major important, you can see that the time to peak effect is 3 to 5 days in warfarin. I think that's the most significant effect. Whereas all the NOACs will have very fast time to peak effect. Dabigatran is just 1 hour, so it is rapid acting, slightly lower in rivaroxaban, whereas 3 hours in apixaban. So that's the reason why you don't need a bridging with heparin for the NOACs. The standard dose warfarin is variable. We need to monitor them and then accordingly adjust the dose. Whereas these are all fixed doses: 150 grams twice a day in dabigatran, 110 milligrams twice a day in or 110. Whereas 20 milligrams or 15 milligrams depending on the renal impairment with rivaroxaban, 5 mg or 2.5 mg twice a day with apixaban. And with 30 milligrams every day or 60 milligrams every day, the adjustment of high exposure in daxaban. Half-life comparable, all 4 drugs around 12 to 14 hours. Renal clearance, nothing much in warfarin, but in dabigatran, as already discussed, maximum in dabigatran, whereas less in other 3 NOACs. So you don't require any anticoagulation monitoring on the NOACs, whereas you require close monitoring in warfarin thing. Antidote, it's a very old slide, so old table. So we'll go to specific antidotes in these drugs, new drugs. So, which is the other trials which are done for other NOAC? I spoke about the Relay trial in dabigatran. So there was a Rocket AF trial for Rivaroxaban, Apixaban, Aristotle trial, and for Edoxaban Engage. So subsequent all these trials showed that all these other NOACs were non-inferior as compared to the warfarin thing. So they were not tried head to head. They were all tried with warfarin. So they were proven to be non-inferior in terms of the primary endpoint as compared to warfarin. So coming to what is the, when we compare these NOACs, dabigatran 150 BD is scores much more higher than other NOACs in comparison to warfarin and other NOACs in terms of stroke and preventing stroke and systemic embolization. Whereas when compared to bleeding, a much more apexaban is much more safer. Whereas 150 dabigatran and rivaroxaban 20 milligrams OD, it's a little higher risk of overall bleeding. When it comes to intracranial hemorrhage, rivaroxaban is a little higher risk. Whereas 150 dabigatran slightly has a lower risk in specifically as if you look at intracranial hemorrhage in various trials. So what are the lab tests you monitor these NOAC? You don't require to do it very regularly, closely, but there are situations where, for example, if there's an hemorrhage, you need to think, or if there is a question of compliance with the medications, then you need to look at these tests when you're using NOAC. Activated APTT, there's no linear relationship with the dose of dabigatran. It is moderately sensitive to the effect of dabigatran. The effect is blunted at higher doses. So you can't measure and monitor APTT, and which is not required as well. Coming to thrombin time, this has a linear dose response relationship with use of dabigatran. It's quite a sensitive marker, and it is is elevated at therapeutic doses. And you combine all three, you can have a clear picture of the activity of dabigatran. The heparin clotting time is also a sensitive test you do in patients on dabigatran. Whereas the other three NOACs, rivaroxaban, apixaban, and edoxaban, we need to look at anti-factor Xa activity, which again is not easily available. So there are few labs which do this test. There's no role of PTINR in patients who are on dabigatran, whereas in patients with other NOAC, PTINR can be a test to compare. Even though the drug interaction is not much with the newer anticoagulants, but we need to be aware of certain drugs which need to be carefully used along with dabigatran. So specifically speaking about P-glycoprotein inhibitors, or CYP3A4 inhibitors. So the ketoconazole, which will significantly increase the concentration of dabigatran and its anticoagulation effect. So it is usually advised to not to use dabigatran with oral ketoconazole. Clarithromycin, there's no dose adjustment required, so you need to be careful with, because anyway it's a short-term use, clarithromycin. So it's not been something, but ketoconazole you need to be careful. It's generally contraindicated. Coming to use with the PGP inducers like rifampicin and carbamazepine, again there is better to avoid using concurrent use of dabigatran with rifampicin, because it reduces the dabigatran concentration, and there can be chances of thrombosis. Carbamazepine should be avoided or used with caution when you're using with dabigatran. Coming to concurrent use of antiplatelet agents, there is no interaction, but definitely the anti-thrombotic effect and anticoagulation effect adds, and there's a higher risk of bleeding risk. So when in the Relay trial, when the dabigatran was combined with clopidogrel, the risk of bleeding was much higher. So aspirin still okay, but clopidogrel you need to be careful. Coming to NSAIDs, the bleeding risk and antiplatelet effects gets enhanced, and the slight increase in the risk of bleeding. The antacids like proton pump inhibitors decrease the dabigatran concentration. So probably we need to be careful when we co-use either pantoprazole or omeprazole with dabigatran. Similarly, PGP inhibitors like amiodarone, verapamil, and digoxin will increase the dabigatran concentration. So it's a very common thing because we are using these patients with AF. We need to use amiodarone or verapamil to control the rates. So these are situations where you may use concurrent. So you need to be careful when they're using. So dose adjustment will be required for these patients. Coming to complications with the dabigatran, the commonest complication, of course, is bleeding. Other than that, specifically related to drug, uh, some patients can have a dyspepsia. There's some trials showed that there is a slight increase in myocardial infection, but maybe it also has some amount of procoagulant effect. That may be the reason, but that again may be a reason why it is not advisable to use in patients with mechanical valves or valvular AF. So it is specifically indicated in non-valvular AF. So that has to be kept in mind. The evidence is all for non-valvular atrial fibrillation and not for valvular, which have hemodynamic problems or mechanical valve, prosthetic valves. So that may be the reason why still we don't have evidence for that. So there may be a slight procoagulant effect as well. We don't, not sure. We also need to be aware of certain risk factors for bleeding, increased bleeding in these patients. So the patients have hepatic renal disease, ethanol abuse, malignancy, old age, and recent bleeding, blood pressure not well controlled, elevated fall risk, or recent strokes. All and patients who are all on antiplatelets, or if there is a reduced platelet count, thrombocytopenia, you need to be very careful while using these patients with the dabigatran. So what you do when you have a patient on dabigatran or any other anticoagulant per se, or a NOAC thing. So look at which is a site of bleeding, assess hemodynamic status, blood pressure, basic cognitive parameters, blood count, kidney function, history very important. What are they on? Whether it's a NOAC or thing, what is the dose of NOAC? What they're using, and if it is just a minor bleed, if it is NOAC, delay NOAC for one dose or one day. If it is moderate to severe bleeding, then add symptomatic fluid replacement, blood transfusions, treat bleeding cause like gastroscopy. Need to stop the bleeding from the GI thing. Or if it is NOAC, you need to consider to add oral charcoal refrigerant ingested NOAC in last few hours. We'll come to the specific antidote, but if it's not available quickly, then you can look at prothrombin complex. I'm not going to details what you do with VK. We are all aware of that. We need to give vitamin K and then followed by FFP or PCC, which is available, whichever is available. So good thing is now we have a specific antidote for dabigatran, which is adrestizumab. And also there's some data on andexanet alpha for the other NOACs. So praxabine, which is adrestizumab, is a monoclonal humanized antibody fragment, which mimics thrombin, that is factor 2, binds exclusively to dabigatran, both free and thrombin factor 2 bound dabigatran, almost 350 higher than the dabigatran's affinity for thrombin. So which is a very high affinity molecule. And then the complex is then eliminated by the kidneys. So what they have found in reverse AD trial is that adrestizumab completely, after given 5 grams, 5 milligrams is infused, 2.5, it comes in 2.5 milligrams vial. After injection, within few minutes, there is a complete reversal of diabetic anticoagulation effects, and it lasts for anywhere between 12 to 24 hours. So it can be either to stop the bleeding, or if there's a question of any procedure to be planned, we can quickly reverse the effect of dabigatran using praxabine and things. So it's been available since 2000, been approved by 2017, and various centers in the country, in the world, have used this with good effect. And if you look at the Revector program, where they have done cross-sectional surveillance program of this drug use for various indications, either location of life-threatening bleeding events like GI tract, intracranial, skin, urogenital tract, various sites of bleeding, or type of surgeries or procedure by indication for rituximab use, I think it has been quite extensive and thing. So the first analysis of it is used in 5 grams of rituximab is used appropriately in 98% of dabigatran treated patients. The rituximab use was consistent with data collected from clinical trial settings. So what are the contraindication for use of dabigatran? Severe renal impairment. If the creatinine clearance is less than 30 ml per minute, you need to avoid using dabigatran. Any previous hypersensitive reactions to dabigatran, drugs like ketoconazole, and even rifampicin for that matter, severe liver disease, mild enzymes up to twice the lower limit, twice the limit of elevation of liver enzymes, we need to not use dabigatran. Hemodynamically significant valvular heart disease or artificial heart valves as a contraindication for dabigatran use. Thrombocytopenia. Pregnancy it comes under category C, it's not safe. So where do you use caution while using dabigatran? If the age is more than 80 years, we know that they will have some amount of renal impairment. Renal creatinine clearance may be little impaired, so you need to check that out and then use it accordingly. Probably use a lower dose. If there is a moderate renal impairment, as I said earlier, history of GI ulcers, resistant gastroesophageal reflux disease, taking concomitant antiplatelets, there's a risk of bleeding there. Drugs which have interaction, which I discussed earlier, recent trauma, surgery, or GI bleeding becomes need to be used with caution. Again, coming back to the role of anticoagulation in stroke, we need to look at specific indications for the neurologist. So the approved indication for dabigatran now presently is DVT prophylaxis pre and post orthopedic surgeries like knee hip replacements, stroke prevention, systemic embolism, reduction in vascular mortality in non-valvular AF. So which are the likely patients one would like to start on dabigatran who require anticoagulation, not on any medications presently? So you want to start a new drug, but there are contraindications warfarin. Patients are not willing to be compliant for PTI monitoring, or you sense that they will not be compliant because ultimately the safety of patients will be very paramount. If they are not likely to come back for PTI monitoring, then they are not the candidates to be started on the vitamin K antagonist like warfarin. So if you sense that, then they are the candidates to be started on NOACs with the proper indications. Who are already on warfarin but non-compliant for monitoring and dietary restrictions, difficult venous access, been on long-term warfarin but have difficulty getting blood sampling, and difficult access to if they're moved, if they're moving around, for them it will be difficult for them to regular monitoring of PTINR, and significant fluctuations in readings etc. becomes an indication to change over from warfarin to NOAC, dabigatran mainly. And if the PTINR is subtherapeutic, despite doing using optimum dose of warfarin, becomes also an indication to change to dabigatran. And patients themselves express that it's difficult for them and they want much more easier way of taking drugs. Then I think dabigatran becomes an indication. So when it comes to atrial fibrillation, as I mentioned, important is to be aware of the CHAT scores for stroke risk in patients with thing. So we look at the history of atrial fibrillation plus the recent cardiac failure, hypertension history, age more than 75 years, diabetes history, stroke or thing. So maximum score is 6. When the score is more than 2, then there is a significant risk of stroke in patients with atrial fibrillation. So there is the indication for oral anticoagulation therapy, and as I said, look at their profile and then decide. I think that becomes a very very good indication for NOAC per se. Coming to CVT dabigatran, there are 2 trials which were done, secret and respect CVT trials. So they looked at safety and efficacy of dabigatran etoxalate versus dose-adjusted warfarin in patients with cerebrovenous thrombosis. It was a randomized controlled trial. They studied around 100 patients. Around 140 patients, sorry. So what they concluded is that patients who had CVT anticoagulated with either dabigatran or warfarin had low risk of recurrent venous thrombotic events, and the risk of bleeding was similar with both medications, suggesting that both dabigatran and warfarin may be safe and effective for preventing recurrent VTs in patients with CVT. So it was found to be non-inferior. It's comparable to use of warfarin. So it's a good indication to look at from the neurologist's point of view, because we are looking at short-term, anywhere between 3 months to 6 months, unless they are having thrombophilia or Apla syndrome. And one other important point to ponder here, We had two patients recently who presented with CVT. One lady, in fact, had a strong family history of factor V mutation and as well as antithrombin 3 deficiencies, significant amount of venous thrombotic events in the family. We thought she also would have that, but she turned out to be APLA syndrome. So we planned to start on NOAC, but we changed her to acetrom because acetrom and warfarin are known to be much more efficacious and safe in patients with APLA syndrome. So if there is a patient with CVT, if there's no specific reason found apart from APLA, then you can consider using it. But again, it's off-label. It's not been proven beyond doubt, and it is not part of the guideline. But that becomes an indication for using NOAC because it's a short-term. Cost is not an issue, and you don't need close monitoring thing. But if there's a APLA reason for having CVT, then acetrom or warfarin are preferred as compared to a NOAC. So which are the conditions where still warfarin is preferable? As I mentioned, CVT due to APLA syndrome. When you look at LV thrombus and stroke, still warfarin is much more effective. Carotid multiple artery dissection and stroke, AF in valvular disease or in mechanical valves, still warfarin is preferable in these conditions. So among the NOAC, how do you choose between different NOACs? When there is a high risk of stroke, when there is a high chart score, more than 3, then I think dabigatran 150 BD, and unless they are more than 80 years old, then dabigatran 150 becomes so its previous stroke. Rivaroxaban is much more effective. High risk of bleeding or previous life-threatening bleedings, lower the dose of dabigatran is 110 BD or apixaban, because apixaban was as compared to the trials, different trials, the risk of bleeding becomes lesser in apixaban, so that becomes much more safer. In patients having already previous history of GI ulcer or dyspepsia, you need to avoid dabigatran. So rivaroxaban and apixaban is much more safer. GI bleeding, apixaban. Medication compliance problems, because rivaroxaban is single day dosing, so that becomes much more easier to use. Edaxaban is still unavailable, so rivaroxaban is much more easier to use, available freely. Elderly patients with impaired renal function, apixaban 2.5 BD is preferable. So summarizing my talk, dabigatran is an effective newer oral anticoagulant both in 110 and 150 milligram doses compared to warfarin in specific indications like VT prophylaxis, DVT prophylaxis, or stroke prevention in atrial fibrillations, non-valvular atrial fibrillations. It has a proven benefit in stroke prevention and DVT prophylaxis. When we consider using it, you need to be careful in patients who are elderly, more than 80 years old, and renal failure patients. We need to monitor them very closely. Of late, all this day, we were worrying whether we have an effective antidote for these patients, but now we have an effective antidote in the form of Praxpine, which is available even in our country, and we can use it when it's required. And also, recent of late, a lot of companies have come out with cheaper options, which are generics. The effectiveness is still not. I'm not sure about the efficacy, but definitely the cost has come down, and so our chance of using it is much more now has become wider. We need more evidence for other indications like valvular AF in patients with mechanical thing and CVT. We need more evidence for that for wider use in our practice. Thank you.